So, hello, everyone. So it's the time we are going to start our expert talk today. Please make sure you choose the right interpretation channel, and then we will start. First of all, I would like to share with everyone the agenda for today's expert talk. For the first 30 minutes, we will have Dr. Broom to give her presentation for approach to Anemias. And then for the next 30 minutes, we will have a QA panel with our guest speaker, Dr. Ramon. First of all, I would like to make a brief introduction for Dr. Broom. She used to be the clinical professor, Department of Pathology, University of California in San Diego. And also she was ad hoc reviewer for the American Journal of Clinical Pathology, American Journal of Pathology. So I will now let me give the time for Dr. Broom. So I would like to give you the authorization to share your PPT. Okay.
All right, well, thank you, Sasha, for that kind introduction. And let me start the screen share.
Okay, I will get off of my presentation. Yes, yeah. So.
Okay, so now I can share?
Yes.
It says you cannot start screen share while other participant is sharing.
Let me see. Okay, 1 minute, please. Okay, so you can share with your PPT right now, please, Dr. Broom.
Okay, well, thank you, Sasha, again for that very kind welcome. So my name is Elizabeth Broom, and it's my pleasure to talk to you today about the approach to anemia. My objective is to help my listeners understand what most physicians use, how they use blood counts and smear review and reports from the clinical laboratory to have a physiologic approach to anemia. And that's to a large extent based on the reticulocyte count, but also the blood cell indices such as the MCV, and most importantly, blood smear findings, especially in cases of hemolytic anemia, to suggest the cause of anemia and to help with choosing additional testing to confirm the diagnosis. Here are my disclosures. So the first step in determining the cause of anemia is to establish that the person actually has anemia. And as I'm sure most of you know, hemoglobin values vary depending on your age, sex, and whether the woman is pregnant. And also, many people aren't as aware that there's up to a 10% diurnal variation in your blood count. So the hemoglobin tends to be higher in the morning and lower in the evening. So so with age, here are some general normal values. These may not be specific to your clinical laboratory, but at birth, the newborn has quite high hemoglobin in the 14 to 20 gram per deciliter range. And then that falls quite quickly after birth, within a month. And then in childhood, it remains about 11 to 14 grams per deciliter. And men have higher hemoglobins than women due to the testosterone effect on red cell production. And pregnant women have a lower hemoglobin than other women, mostly due to hemodilution. So they have increased blood volume and diluted red cell numbers. So the physiologic approach to anemia is to categorize, make a general categorization between decreased production, an example of that is aplastic anemia, and increased destruction, blood loss. An example would be sickle cell anemia. And the reticulocyte count is critical to distinguish between decreased production versus increased destruction and blood loss, destruction or blood loss. And here's a picture of a reticulocyte, a couple of reticulocytes here in the middle of the blood smear image. And this is from a stain with new methylene blue from peripheral blood. And reticulocytes are newly formed red cells that have just left the marrow. They circulate for about a day, and they have increased polyribosomes, which are the machinery for making hemoglobin. These, as they mature in the blood, they lose these polyribosomes. And these particular stains are important for identifying reticulocytes. You can't see them easily or very easy to quantify on a regular right Giemsa stain smear. You have to do a special stain such as a new methylene blue stain. Now, most high-end hematology analyzers today do automated reticulocyte counts using fluorescent stains, also staining for the RNA content of the cells, and flow cytometry type method. So again, continuing the physiologic approach to anemia. So the reticulocyte count distinguishes between anemia due to decreased production versus an increased destruction and blood loss. But the percent reticulocytes alone is not a reliable way of distinguishing between these two general categories of anemia. You have to do either a conversion, such as the classic one is the reticulocyte index, or use the absolute reticulocyte count, and I'll get into that in a minute. So the reticulocyte index needs to be more than 2, and if the patient has an appropriate response to being significantly anemic and having significant anemia. And the reticulocyte index varies depending upon, the factor that you use to calculate the reticulocyte index varies depending upon the degree of anemia. So if the hemoglobin is about 8 to 10, then the factor would be 2. If the hemoglobin is less than 8, then the factor would be 2.5. And here's the formula for calculating the reticulocyte index. It's the hemoglobin divided by the normal hemoglobin times the percent reticulocytes and then divided by this factor that corrects for the degree of anemia. And this factor is again related to the fact that these stress reticulocytes circulate longer in the live longer in the circulation than normal reticulocytes. So they may live a couple of days versus normal reticulocytes are only circulating for about a day. So here's an example. If a patient has anemia of 10 grams per deciliter and the reticulocyte count percentage is 9%, then the index would be 1/2, that correction factor, times 10 divided by 15, which is 15 would be a normal hemoglobin, say this was a man, times 9%. And so the reticulocyte index would be 3. And that would indicate a appropriate response to this degree of anemia. So the marrow is responding appropriately, and this would be consistent with a hemolytic anemia or a blood loss anemia. Less than 6% reticulocytes in this particular example would indicate a borderline or low marrow response because the reticulocyte index would be less than 2. Now, if you have an acute hemolytic event or an acute blood loss, then your reticulocyte count may not be elevated. So it takes about a day or 2 for your reticulocytes to increase after an acute blood loss or an acute hemolytic event. So we're talking This is most useful in a more steady state, sort of chronic anemia situation. Now, I prefer to think about and use the absolute reticulocyte count as opposed to this reticulocyte index. And the absolute reticulocyte count is the reticulocyte percentage times the red blood cell count. And it's usually provided automatically by these hematology analyzers that measure reticulocytes. So the normal absolute reticulocyte count is about 50,000 per microliter. And if you have an absolute reticulocyte count of more than 100 to 150,000, that means the marrow is responding well to the degree of anemia. And again, remember that reticulocyte counts may lag if you have an acute episode of blood loss or hemolysis, maybe 24 to 48 hours later. So now I'm going to talk about hemolytic anemia in general. So we've established the fact that the patient has an ongoing anemia, somewhat maybe subacute, somewhat chronic, and they have an increased reticulocyte index or an absolute reticulocyte count of more than 150,000. So they have increased red cell destruction with appropriately increased reticulocytes. Worldwide, the most common cause of hemolytic anemia is malaria. And here is my niece dressed as a malaria parasite in her red cell for Halloween. So once you've established the fact that you have a hemolytic anemia, then one of the next questions is, in this physiologic approach, is the hemolysis extravascular or intravascular? Extravascular means that the red cell destruction is taking place within the phagocytic cells of the spleen or liver. Intravascular means that the hemolysis is occurring within the lumen of the blood vessels. And I'm going to focus in this talk mostly on extravascular, partly because the blood smear interpretation is very helpful, and the lab plays, especially the hematology lab, plays a very important role in determining the cause of extravascular hemolysis. Intravascular, the lab, mostly the chemistry lab, will have more of a role in determining that there is intravascular hemolysis by doing the urinalysis, looking for blood in the urine and in the plasma. So you'll actually have circulating free hemoglobin that you can measure. The leading causes of intravascular are sepsis, and here you have malaria again, severe microangiopathic or mechanical hemolysis, so where the blood is being destroyed by going through fibrin strands, or occasionally, hopefully rarely in this day and age, transfusion mismatches. Usually it has to be pretty severe, such as ABO mismatch. And then there are these rare entities called paroxysmal nocturnal hemoglobinuria and paroxysmal cold hemoglobinuria, which I'm really not going to talk more about, but they can cause episodic intravascular hemolysis. So here is a scanning electron microscope of a spleen, and these are the cords of Billroth, if you remember this from your anatomy and histology. And here is a red cell that is squeezing through this fenestration in the cords of Billroth, here's our other red cells going from a lumen of a vessel through these walls in the splenic vasculature into a sinus and then continuing out of the spleen. And so in order for a red cell to get through this narrow fenestration in the walls of the vessels, they have to have really good deformability. And if they have an abnormal shape, that can interfere with their ability to deform and get through the fenestrations. And such an abnormal shape, I'll get into in a minute, would be such as spherocytes. So instead of being a normal biconcave disc, they would be spherocytic and have trouble getting through these fenestrations and maybe removed from circulation and have their contents destroyed or recycled, resulting in the sign of hemolysis, which would be increased LDH and bilirubin. So again, here's the red cell, a normal schematic of it. It's a biconcave disc, so it's got, or sort of donut toroid shaped, and that results in this appearance on a bright Giemsa stain smear, where you can see the central pallor and the sort of donut appearance. And if that shape becomes abnormal, either ovalocytes or spherocytes, then that can cause problems with getting through that splenic sort of filtering mechanism. And here's a schematic of the red cell membrane. And there's a cytoskeleton of proteins that are just below the membrane. So here is the lipid membrane of the cell, and just below that lipid membrane is this network of cytoskeletal proteins. And then there are these transmembrane proteins here that this network of cytoskeletal membranes are attached to. And hereditary spherocytosis and hereditary ovalocytosis, which are very common autosomal dominant genetic diseases of red cell morphology that affect red cell morphology, result from mutations of some of these red cell proteins. In fact, it's many different mutations. So it's not just one mutation that can result in the spherocytosis and ovalocytosis. So again, the increased destruction from hemolytic anemia, you have an elevated reticulocyte index or absolute reticulocyte count, but you also have elevated indirect bilirubin and LDH1. So that is sort of the hallmark, the chemistry hallmark, confirming that there is hemolysis going on. But you can have the increased bilirubin and LDH1 in other diseases besides on hemolytic anemia, including ineffective erythropoiesis. And that is a classic example is folate or B12 deficiency. So those patients can get quite jaundiced associated with those nutritional deficiencies. But I wanted to now focus on how RBC morphology can be really useful in focusing further investigation of hemolytic anemias. Oops, why is it not advancing? There we go. So here are some important red cell morphology findings that you can see on blood smear that will help determine the further investigation of hemolytic anemias. So once you've established that you have a hemolytic anemia, you look at the blood smear, and if you see ovalocytes, spherocytes, schistocytes, target cells, or bite cells, then that would help determine additional testing. And so ovalocytes are associated with hereditary ovalocytosis, spherocytes are associated with autoimmune hemolytic anemia or hereditary spherocytosis. For the autoimmune hemolytic anemia, you would do the Coombs test and look for antibodies on the surface of the red cells. And I'll get into the additional testing for these other entities in a minute. For schistocytes, the cause might be microangiopathic hemolytic anemia. And that's due to the red cells being sheared while circulating, and they're being broken up by strands of fibrin or von Willebrand's factor. Target cells are associated with liver disease, but also hemoglobinopathies, in particular sickle cell or hemoglobin C. And then thalassemias can also have target cells. I'm sorry, this table got a little messed up. This was supposed to be under here. And then bite cells indicate oxidative stress, and I'll get into that in a minute more here. So here's an example of spherocytes. Let me do a drink. Again, these are associated with autoimmune hemolytic anemia versus hereditary spherocytosis. Now, the important thing about spherocytes is they are a common blood smear artifact. So you really have to be sure you're in a good area of the blood smear before you start calling spherocytes. And whenever there are pathologically significant spherocytes, they're almost always in a minority. So they're just a few percent of the total cells. So you really want to be in an area of the smear where the cells aren't touching, and that many of the cells have normal, central pallor appearance. And the spherocytes that are significant will be smaller than the normal cells. They'll have increased coloration, so they'll be hyperchromatic, and they won't have any central pallor. So here's a couple of good examples of spherocytes. And so hereditary spherocytosis is due to defects in those cytoskeletal proteins that affect the structure of the cell skeleton, and they means that when they go through the spleen, little bits of the membrane is removed from the cell. So they become smaller and they lose their surface area. So their surface to volume decreases and they become spherocytes instead of more of the normal discocyte or donut-shaped cell. And it is autosomal dominant and fairly common, especially in Northern Europeans. It's as many as 1 in 1,000, but quite variable in its severity. Some people have such a severe disease that they end up needing a splenectomy. Most people live fairly normal lives. They are at risk of getting pigmented gallstones, but otherwise it's just a fairly benign inherited disorder that causes minimal problems for the patients, but something to be aware of and not to be confused with autoimmune hemolytic anemia that also can cause spherocytes. So schistocytes are very significant, and when you see them on a blood smear, they can be really indicate that the person has a potentially life-threatening disease. So these are, and they're usually acquired. People aren't generally born having schistocytes. These are fragmented red cells that are caused by strands of fibrin or von Willebrands in the blood vessel. And so this, hemolytic anemias with schistocytes kind of straddle between being intravascular versus extravascular. And if it's a severe form of it, then they can have signs that it's actually intravascular. And the causes of increased schistocytes include disseminated intravascular coagulation, which is due to deposition of fibrin in the vasculature, thrombotic thrombocytopenic purpura, which is deposition of von Willebrand's factor in the circulation, and hemolytic uremic syndrome, which is also associated with deposition of von Willebrand's, but more limited to the kidney area, and they have severe renal dysfunction. And as I said, these are usually acquired, so it's not congenital, although there are some rare instances of people having mutations that make them vulnerable to develop, in particular, TTP. And it's important to bring this to the clinician's attention if you see it, and they would do additional testing to determine the cause. Of course, sickle cells can be confused with schistocytes, but they do have a somewhat distinct appearance. Usually there's more sickle shape, not such an irregular fragmented shape. And they often are associated with increased target cells. And sickle cells are associated with sickle cell anemia, a homozygous mutation of the hemoglobin beta chain gene. And then target cells also can occur in thalassemias and liver disease. Also wanted to mention nucleated red cells are often associated with sickle cell anemia and are associated with severe hemolytic anemias. Whenever there's a severely stressed marrow, you can have both increased reticulocytes and circulating nucleated red cells, although the reticulocytes occur much early with a much more mild hemolytic anemia, and it's only with very severe forms that you get circulating nucleated red cells, or in the case of sickle cell anemia, when they've had their spleen infarcted or now becomes not functional, then you get more circulating nucleated red cells. Bite cells, I wanted to mention bite cells. They can also be confused with schistocytes, but in general, they're somewhat distinct in appearance. They're just on the edge of the cell. Here's some classic bite cells. And bite cells are due to precipitated hemoglobin that is removed by the spleen, and in the process of removal, sort of a chunk of the membrane is removed. And it's associated with particular drugs. And classic one is dapsone, but also enzyme deficiencies, and in particular glucose 6-phosphate dehydrogenase deficiency, which is again a fairly common deficiency and usually doesn't cause problems except when patients are exposed to drugs that cause oxidative stress to the hemoglobin. I wanted to stress that RBC morphology reporting should be done with some sort of indication of the severity, how much of the morphology is present. So usually labs classically have done sort of a grading system of 1+, 2+, 3+, and this would be the percentage of abnormal red cells that would give it 1+ for each of these morphologic categories. And again, I want to stress that even these abnormal cells, in particular spherocytes, are a minority of the cells. We're not talking all the cells. So if it looks like all the cells, then you're probably not in a good area of the smear to evaluate for these red cell morphology abnormalities. And we haven't mentioned teardrop cells, but those also can be very important for suggesting pathology. They're not necessarily associated so much with hemolytic anemias. So if you're going to follow up on these red cell morphology abnormalities for the ovalocytes and spherocytes, family history is important. They're due to autosomal dominant. So usually one of the parents would also have the same abnormality, and due to red cell skeletal membrane abnormalities. Spherocytes, the Coombs test to evaluate for possible autoimmune hemolytic anemia. Schistocytes, you do the COAG test, neurologic examination, renal tests. And this particular E. coli infection can cause the hemolytic uremic syndrome. Target cells, you can look at liver function and hemoglobin electrophoresis, looking for abnormal hemoglobins. And then the bite cells, you need to do the G6PD enzyme levels and a history of drug exposure. Now I'd like to move on to anemias with a low MCV and low reticulocytes. So I've finished with the hemolytic anemias and anemias with high reticulocytes, and now I'm moving on to the category of low reticulocytes, and we're going to start with, and in those ones, anemias, the MCV can be very helpful in focusing the investigation of the cause of anemia. So the differential diagnosis of low reticulocytes and low MCV is iron deficiency, thalassemia trait, anemia chronic disease, and sideroblastic anemia. And the laboratory evaluation then is with iron, transferrin, and ferritin. You can look at the blood smear. If you see target cells and stippling, then that would maybe suggest more thalassemia. And pencil cells are classically seen with iron deficiency. Hemoglobin electrophoresis quantifying hemoglobin A2 is also helpful to determine if the patient has beta thalassemia. And then you can also, if absolutely necessary, look at the bone marrow for iron stores, but usually that's not done unless you happen to be doing a bone marrow for other reasons. Oh, this table got a little messed up too. But in iron deficiency, of course, your serum iron is low, your transferrin generally is high, and the ferritin is low, and the RDW is high. Chronic inflammation, the ferritin can be normal or high, but generally the transferrin is normal to low. And thalassemia, all of your iron studies should be high, except the RDW will be high. And here's an example of pencil cells, really very extreme example. And you can also see the red cells are hypochromic, meaning the central pallor is more than normal, more than a third of the diameter. So this would be an example of classic iron deficiency. And these are not entirely specific, these severe ovalocytes or pencil cells, but it's very suggestive of iron deficiency. And here's an example of somebody that has thalassemia with basophilic stippling and a few target cells. So that would be, and also again, you can see there's increased central pallor. So just as in iron deficiency, these patients will have increased central pallor of their red cells. So now we're going to talk about normal MCV instead of the low MCV and low reticulocytes. And that's due to primary bone marrow failure, such as acquired or congenital aplastic anemia, bone marrow fibrosis. Secondary causes can be metabolic, such as uremia, endocrine disorders, infection, HIV is a good example. And in HIV, especially untreated, their MCV may be elevated though. Anemia, chronic inflammation, and metastatic cancer in the marrow. Here's an example of a patient with myelofibrosis. I mentioned the teardrop cells, and teardrop cells are classically seen when you have any infiltrative disease of the marrow, and associated findings with marrow fibrosis include circulating immature granulocytes and circulating nucleated red cells. The term for that blood smear is called leukoerythroblastic blood smear, and it's associated with myelofibrosis and infiltration of the marrow by, say, cancer. So here's an example of a picture of the marrow with a lot of fibrosis. Normally there would be fat cells and marrow producing cells, blood producing cells in this marrow, but instead it's been replaced by fibrous tissue. And then the category of macrocytic anemia. So now we're talking high MCV with low reticulocyte count. And just one point about that is that high reticulocytes can cause a macrocytosis. So high MCV up to as much as 105 femtoliters. But we're talking now, if you have established that the patient has low reticulocytes, then one of the possibilities with a macrocytic anemia is B12 folate deficiency, treatment with drugs that can interfere with DNA synthesis, such as cancer treatments, immunosuppressives, some antivirals. And myelodysplasia, myelodysplastic syndromes can also cause a low reticulocytes with high MCV. And for B12 folate, here's an example of a hypersegmented neutrophil in the peripheral blood that can help clue you into the possibility of that diagnosis. And for myelodysplastic syndrome, here's an example of a pseudo-Pelger-Hewitt cell, or I'm sorry, a Pelger-Hewitt cell, which is a bilobed neutrophil. And if you have a large number of those, usually more than 10 or so %, then that is suggestive that the patient may have myelodysplastic syndrome or be being treated with certain drugs that can cause that same appearance. So in summary, the approach to the anemias is initially to determine if the anemia is due to decreased production or increased destruction, which can also include blood loss. For decreased production, use MCV to focus your further investigation. And for hemolytic anemias, the smear morphology and ancillary studies as the smear morphology can help very much in focusing your additional studies to determine the cause. And thank you very much for your attention. And I will now turn it over to Sasha and questions.
Okay, thanks for Dr. Broom's excellent presentation. So let's come to our Q&A part. I will share my screen. Okay. Yeah, before this, for Q&A part, we will invite Dr. Ramon. He will be our guest speaker. He's now working mainly as a scientific research and clinic affairs. And so, Dr. Ramon?
Yes.
Dr. Ramon, can you hear me? Yeah, so
Yes,
now it's your turn.
Yes.
Okay.
Okay.
So let's first,
yes, we
okay,
have collected
please.
some questions. The first one, and congratulations, Dr. Broom, for your nice talk. It was it's very complicated anemia. You make it very simple and very easy. Was really a great talk. And and we have some questions. The first one is, which inflammation marker you think can be good to diagnose anemia of chronic inflammation in the routine anemia differential diagnosis?
Oh, that can be a challenging one. I'm sort of anemia of chronic inflammation often is a diagnosis of exclusion. I know one of the classic examples of anemia of chronic inflammation in trying to evaluate for that versus iron deficiency is patients that are on dialysis. And the National Chronic Kidney Disease Foundation in the United States has pretty much focused on ferritin as being the best measure. And so they will use a cutoff of a ferritin as much as 200 to determine if the patient may benefit from intravenous iron therapy. But another up-and-coming measurement to distinguish iron deficiency from anemia of chronic inflammation is the reticulocyte hemoglobin content. And a number of in fact, the National Chronic Kidney Disease Foundation has started recommending that measurement as well to help distinguish between patients that may benefit from iron treatment as well as growth factor treatment, that have kidney disease. So that's and the other inflammatory markers, such as actually I'm blocking on the names of them. They're not that specific or reliable. So it's usually comes down to distinguishing between whether the person is truly iron deficient or not. And of course, you can use rheumatoid because one of the classic examples of anemia of chronic inflammation is patients with rheumatoid arthritis or other rheumatologic diseases. So you really need to sort of evaluate what is the chronic inflammatory cause, what's underlying it, and try to determine if they truly meet that category. And what's also super important is not to treat patients that are have thalassemia with iron, because that can cause a lot of problems with iron overload down the road. So you want to evaluate for the possibility of thalassemia as well. So it's, in my understanding is it's mostly a diagnosis of exclusion, excluding iron deficiency, excluding thalassemia.
Okay, perfect. Thank you. The second question is how to suspect cases of hemolytic anemia, of course, not very severe, a mild hemolytic anemia, or cases with spherocytes only with a CBC in a checkup or in any control, how we can suspect in order to do blood smear or to do any test to see the spherocytes.
The classically hereditary spherocytosis or autoimmune hemolytic anemia will be associated with a slightly increased mean corpuscular hemoglobin concentration.
Mhm.
And also a slightly lower MCV and more of a RDW, higher RDW, because there'll be normal cells and the spherocytes, so you'll have a larger spectrum. But none of those are very specific, I would say. And as I think people in the clinical laboratory know, the MCHC can vary a lot and somewhat depends on if there's any mild degree of hemolysis in the blood sample. So I don't think it's a very reliable test. So I would say if there is anemia, you look at the blood smear. And the critical thing about spherocytes, again, is having a good smear. So many times people will be looking at these smears and you can't find a good area. Everything looks spherocytic and you're left really without, you just really can't determine. So critical is to have a good smear, go to an area where most of the cells have good central pallor, and then do your estimation of the spherocytes. And if they're increased, and then especially if they're 2 or 3+, then it's would be important to, and there's evidence of hemolysis, meaning the person has elevated LDH or bilirubin, then you'd need to do the other test, the Coombs test, and evaluate the family history.
No, and also maybe the reticulocytes will be higher, that will confirm that these are really spherocytes, no? Maybe.
Oh, yeah, that's true. I mean, you're obviously, yeah, I sort of
because
assume
this is the question, I think.
anemia.
But
Yeah,
this is the question. With reticulocytes, it's easier to detect hemolytic anemia and spherocytes because normally they come with a high reticulocyte count. But the question is, and you said the point, RDW, MCHC, even that they have some abnormal situations that can increase. But this is what we are working with to screen, to create a rule when you, and to do a blood smear or to do, and you answer perfectly. Yeah, it's the same that. Maybe the next question, maybe how to use automated NRBC count in the anemia differential diagnosis. Can this be higher, maybe in hemolytic anemias? Even if it's, that will be the next question.
Well, NRBCs will be elevated and in patients with severe hemolytic anemia, or in cases of leukoerythroblastic type picture in their marrow. And so if you have elevated nucleated red cells and immature granulocytes, then of course you'd really want to look at the blood smear and see if there's teardrop cells, that the person may have some marrow infiltrative process or fibrosis. And nucleated red cells are very characteristic of, especially of adults with sickle cell anemia. You'll see many nucleated red cells in those patients. So it's important to pay attention to the NRBCs, but in more subtle cases of hemolytic anemia, they're not necessarily going to be elevated. So it's only in more severe cases that they're elevated.
Okay, the next question comes from Argentina. How important do you consider to observe the blood smear to see morphology and or alterations of red cells, white cells, and platelets, as well as the presence of absence of blast and circulating erythroblast? The point, there are more than 40% of anemias in a hospital setting every day. How many slides we have to do to see the blood, the red cells for the differential diagnosis of anemia?
Well, everybody has their rules for when to make a blood smear, when to look at it. And I could share those rules with you. And we would make a smear on any patient that had a platelet count that was low for the first time. And then if we didn't see anything, we wouldn't necessarily look at the blood smear again for, I believe it was a week. So these patients that are in the hospital, we wouldn't always be looking at their blood smear because their platelet count was low. But if they came in with a low platelet, we'd always look at their blood smear. And I think that's very important. You don't want to miss schistocytes, for example, on somebody that comes in with a low platelet count. So that's see what else. Abnormal white cells. Again, the increased immature granulocytes is the most common cause. I mean, all these analyzers will, most of the high-end analyzers quantify immature granulocytes very reliably. And then you have to make a decision about what cutoff to look at the blood smear, how high a level of immature granulocytes warrant looking at the blood smear. And we were pretty conservative on that. We would look at them, I think it was at maybe as low as 2%, I think was our cutoff, but most labs, I think, use 5% immature granulocytes to decide to look at the blood smear. And so you just have to come, and again, you can use a time frame where you would look at the blood smear the first time, say if there was elevated immature granulocytes, but not look at it again for another week. Generally, we used a week as an interval, but I'm not, that was somewhat arbitrary, I'd say, that only a week, but that was something we chose and didn't seem to cause us any problems. We didn't really find that we were missing anything. So I would say it's very important to look at blood smears the first time that you see a patient that has abnormalities, because in the laboratory, you're operating in kind of a vacuum. You don't know the patient history, you don't know what's going on. So you have to walk this line of looking at stuff, but not wasting too much time looking at it. And I would say you also need to rely on your clinicians to notify you or know when they think they should look at a blood smear. And at UCSD, we had the ability for the clinicians to order a blood smear right up front. And so they would say they wanted us to look, or they would look at it themselves. And that's important for the lab to be very responsive and interactive with the clinicians so that when they suspect something's going on that a blood smear review would help evaluate, then they can order it and look at it themselves or have you look at it.
This is a very good idea, by the way, because you know there is no in the order form for CBC, there is no manual blood smear in many of the hospitals. And I think I agree with you. This is a very good idea that when the doctors check iron, check B12, and they don't find the reason for anemia is to check, or it's a strange case, yeah, to order blood smear directly. That is a very good idea. Thank you. We have another question from
Q&A box. We have a lot of, yeah, Dr. Bru and Dr. Ramon, we can check Q&A box. We have a lot of questions. Maybe we can choose some featured questions. Yeah, so Dr. Bru, can you check the Q&A box, the questions there?
Okay, let me see the Q&A. Yeah, I can choose one of them. Yeah.
Okay.
What the cause of bite cells in G6PD deficiency from Indonesia?
So the cause of bite cells in G6PD.
What the causes of bite cell in G6PD deficiency?
Okay, so the cause is precipitated hemoglobin. The G6PD deficiency causes deficiency of red cell metabolic material, and they have a low ATP level, I believe, and that causes problems with the redox and oxidative stress to the cells. So the hemoglobin actually gets oxidized, and then it does not remain soluble and it precipitates in the cell. You may not be aware, but red cells have enormous concentration of protein that is in a semi-soluble form, and any perturbation of it by oxidation or other changes can cause precipitation, and then it gets removed from these little bits of precipitated hemoglobin, which you can see on some stained smears. They're called Heinz bodies. They get plucked out of the red cells, and that causes the membrane to get torn, and that happens in the spleen.
Okay, perfect. We have another question from Siti Subaida Mustafa. in hemolysis due to B12 folate deficiency, which RBC morphology is commonly seen? Spherocytes or fragmented cells?
B12 and folate deficiency can cause kind of varied blood smear appearance, but spherocytes is not classic. It's more sort of ovalocytes, and they're called macro-ovalocytes. Also, fragmented cells are generally not seen in B12 folate deficiency either. So it's more macro-ovalocytes and some teardrop cells is the most common morphology that you'll see in B12 folate.
Yeah, I agree. What Ngozi Obuju, what do you expect in red cell indices of patients with such aliment? I don't know what is the question. Maybe he can answer. He can write again. We don't understand what the question. Another question from Siti Zubaida Mustafa. Do you have a general cutoff percentage of spherocytes in neonates to say it is hemolysis?
Oh, and that's a good question. Children, babies' blood smears, it can have a lot of sort of minimal central pallor. It can be very challenging to say what is a spherocyte in a newborn's blood smear. But I would say what they rely on, and hereditary spherocytosis in the newborn period can cause significant hemolysis. And they rely on the bilirubin and LDH levels to determine that there is hemolysis, and also they're obviously they become fairly anemic, and their reticulocytes will be very high. Actually, I suspect you really have to look at the parents if you can to determine if they are at risk of if there's either parent has a history of spherocytes. Because, as I said, the blood smear in newborns is challenging. And actually, I did not work in a pediatric hospital, so I can't. We did have newborns, though, and I do remember that the blood smears are challenging. I don't have a good answer for you on that one. I'm sorry. Finding spherocytes in newborns is, I think, one of the more challenging things. And I don't know that I'd have to really do some research about whether people have come up with a percentage cutoff for that. I will say that the spherocytes that are significant generally are smaller and hyperchromatic, so you would look for that.
Yeah.
That might help you.
I also don't know about the cutoff for spherocytes in newborns. I don't know either. Okay. The other thing is from Colombia. You have presented a slide from an author, I don't remember the author you mentioned, about how to quantify the morphological abnormalities in peripheral blood. He asked if you recommend ICSH, or maybe you recommend this other author that you have shown from International Journal of Laboratory Hematology in your presentation. Which one is the best? Yours, the ICSH, both?
I'm sorry, where are we? Which question is this?
From Colombia, how you can quantify the morphological abnormalities of red cells. There is one proposal from International Council for Standardization in Hematology, and I have seen that you have shown another one.
Yeah, Dr. Ramon, I think this question in
ICSH,
Spanish.
Which recommend you to quantify the Yes.
Yeah, I think Dr. Ramon is translating it.
Yeah.
And
I'm
not sure I understand.
Excuse me, Dr. Ramon. I think this question is in Spanish, so it will get some confused for Dr.
Do you want me to
Broom.
answer?
Yeah.
I'm not sure I'm following the question.
Do
It
you
says,
want me
how
to
do you?
answer?
Yeah, why don't you go ahead and answer, because I'm not totally sure I understand the question.
Yeah.
Yes, of
So
course,
how do you
I recommend the ICSH. I participated also in these rules, and I think it was a world consensus about how to quantify.
Oh, how to
Spanish?
quantify the red cell morphology? Yeah, the International Society of Laboratory Hematology. Yes. Yeah, and in my presentation, I gave a reference a very good reference by Constantino to how to the sort of consensus on quantifying red cell abnormalities. And I would refer people to that article. I think that's a good one.
Let me translate to Spanish. The people from Colombia, la doctora Brum recomienda utilizar, sí, lo que ha presentado ella en su presentación del doctor Constantino, que se publicó en el International Journal Laboratory Hematology, creo que era el 2014, y es lo que ella recomienda, por supuesto, para cuantificar las alteraciones de sangre roja, porque es importante que todos los laboratorios y todos los hospitales usen la misma forma de cuantificarlo, por si el paciente va a uno u otro hospital, que todos digan lo mismo. Okay, there is another question from Iskandar Hardijadinata. He is concerned about the quality of mean cell volume, MCV, in cases with very low RBC count. I don't know why, but he's asking this question. He says that it's no longer reliable. What is your opinion about that?
Excuse me. So Dr. Brum and Dr. Ramon, this is going to be our last question, okay? Because for the time limitation, okay? Let's finish the last question. Okay, thank you.
Okay, well, thank you, Sasha. I am not aware of a cutoff for a low red cell count as far as determining MCV. All of the analyzers I've used would give an MCV even with very low red counts. So I'm not sure how this would be a question. Are you, Dr. Ramon, are you aware of a problem with MCVs with low red counts?
Absolutely the same than you. I never heard that in cases with low red blood cell count, the MCV is not reliable. I never heard that, and I never seen any CF from any company. No, I am not aware about that. As far as I know, all the companies that I know, the main ones, have a good reliable MCV in cases of low red blood cells.
Okay, thank you. Since we have a lot of questions, and after this webinar, I will collect all the questions for Dr. Brum, and then we will get the answer from Dr. Brum. I will post it on the LabClub app, so everyone, you can check after that. For today, due to the time limited, so we are going to finish. So thanks a lot for Dr. Brum's excellent presentation, and thanks for Dr. Ramon's host. Thank you. So we will come to the next part. It's a brief introduction for our expert talk panel. This is an exclusive program on our LabClub, and by now we have already finished the presentation of Dr. Cosgrove, Dr. Gina, and Dr. Brum. And for the next several months, we'll have some more experts to share their ideas. And for more information, you can download this app, the LabClub app, and you will check the record for all the videos, and you will know the upcoming events. Later, we'll show this QR code
Thank you, Sasha.
Yes. So thank you, Dr. Brum.
Thank you. Thanks. Very nice opportunity.
So next time we will, So I saw some people asking for more webinar for the next time. We will do that for another expert talk with your presentation. And so for the next one, Dr. Ramon will give the expert talk for the topic from the CBC to diagnosis of leukemia and lymphoma. Around September 28th, we will send everyone the poster then. And then for the last, please scan the QR code to finish the survey in 1 minute today, and we will see you. Thank you. Thanks for everyone. Thank you. Thanks for Dr. Brum. Thanks for Dr. Ramon. Thank you.
Right.
You're
Bye.
welcome.
Thanks.
Bye.
Bye-bye.
Goodbye. Bye.
Bye-bye.
Bye.